Okay, this is about the adverse effects. Then drug interactions. We told about this discharge toxicity, elevated serum lithium. Okay, why there is elevated serum lithium? Any idea? See, this lithium is observed from the proximal part. Okay, the collecting tubules where our principal cells are working, and through the sodium channels, this lithium will be active. Okay, that I'll be explaining it today. Okay, aminoglycosides increase water toxicity. As you already know that aminoglycosides are the water toxic drugs. These water toxic drugs, again, in our system, what it is doing, it is affecting our lymphatic system, and it can cause this. It can affect the fluid levels at the cerebral canals and also cause this water toxicity. There is diminished action of this NSAIDs. Okay, how do these NSAIDs act? They act by inhibiting the prostaglandin synthesis. Okay, so we normally what these prostaglandins do? They are involved in salt and water excretion. Okay, the prostaglandin mediated salt and water excretion will be there. But if we are using both together, they can diminish the action of this NSAIDs. Probenecid, competitive inhibition, we discussed about it. Then cotrimoxazole, it can cause this thrombocytopenia. Thiazide group of diuretics, they act by inhibiting the sodium chloride co-transporter system at the DCT. Okay, they also have this weak inhibition of carbonic anhydrase inhibitor by virtue of their structure similar to the astazolamide. So they are involved in bicarbonate excretion also because of this carbonic anhydrase inhibitor action. They can excrete this potassium, magnesium, and also decrease the calcium excretion. How calcium excretion is decreased? You saw. Okay, they were under the influence of parathyroid hormone. We have two channels. One is the luminal side, which helps in taking in the calcium. At the basolateral side, we have the sodium calcium antiport mechanism. Okay. Here is the luminal side, here is the basolateral side. Normally they both come in. Okay. Once they both come in, we have the sodium potassium ATP system, which is efficiently working. Sodium will be transported in, potassium will be thrown out into the cell. The chloride has its own channels at the basolateral side for its consumption. So once they are blocked, okay, once they are blocked by thiazide, there will be stoppage of this entering the calcium channels here. They will be transferring the calcium, but the sodium input for the sodium potassium ATP system to work is decreased. What it does, as the sodium is thrown into the cell with the exchange of the calcium here, the basolateral side calcium sodium antiport system, more amount of need is there, but the feed is not there. The feed from this side is not there. Okay, this need system, which is due to the sodium potassium ATP system, will trigger the antiport system more and more. So more and more calcium reabsorption, more sodium for the sodium potassium ATP system to work. That's how the system works there. Okay, we can use both thiazide and diuretics basically for hypertension, congestive heart failure, hypercalciuria, osteoporotic conditions, as it can conserve the calcium. Nephrogenic diabetes insipidus, for this condition we can use it. So sometimes you can get a question in your viva, okay, which is the drug which is having a diuretic action but also have some anti-diuretic property. Okay, that drug will be our thiazide, because in case of this diabetes insipidus, what can happen? There is more amount of, naturally in case of diabetes insipidus, there will be more amount of urine formation. But in that case, our thiazide diuretics can decrease the urine formation. Okay, in case of diabetes insipidus, we can decrease the urine formation. So your answer should be thiazide diuretics are the diuretics which can have antidiuretic action in disease conditions such as diabetes-insipidus. Okay. Then, in case of treatment of lithium toxicity, we can use this drug. THIAZIDES-adverse effects: hypokalemia, hyponatremia, hyperglycemia, that is relative, then hypochloremic alkalosis. Okay, so this can also be seen in the previous one, that is loop diuretics also. Okay, so diminished insulin secretion, elevated plasma lipid, hyperuricemia, hypercalcemia, and hypersensitivity reaction because of the thiazide which has a structure similar to sulfonamide diuretics. So you might be knowing sulfonamides are the brightest drugs which bring about so many adverse drug reactions starting from Stevens-Johnson syndrome, exposure to dermatitis, all type of other minor allergic reactions. So the next group of drugs are the potassium sparing diuretics. Okay, so potassium sparing diuretics, we have two group of drugs. One is the aldosterone antagonist, and the other one is the drugs which can directly act on the DNAs or the epithelial sodium channels. Okay, so spironolactone is a steroid compound which can competitively antagonize the action of the aldosterone receptors. So you might have heard about how this hormonal receptor system work. Okay, how these hormones work? They go to the DNA, they synthesize the particular mRNA synthesis. This particular mRNA will go and induce the important proteins which are needed for the biological activity. Those proteins here are the aldosterone-rich proteins, that is AIPs. Once this AIP formation is decreased, you can expect both one at the luminal side change, one at the basolateral side. On the luminal side, what can happen? The sodium channels which are there, okay, here are the sodium channels, here are the sodium potassium ATPase system. Once aldosterone induced peptides are there, okay, once it binds to the receptor, both are increased. Sodium channels at the luminal side, sodium potassium ATPase system which are lying down dormant inside the cell, they can be thrown out on the basolateral side. This is how it works. But if this aldosterone peptide is decreased, what can happen? Less amount of channel expressed on the luminal side and less amount of sodium potassium ATPase system work on the basolateral side. So we spoke something about the electronegativity which is created here. Why electronegativity was created here? Yes? Why electronegativity was created here? Yeah? First benchers, why electronegativity was created here? We spoke something about electronegativity here, no? Yes? Anyone? See, the normal blood flow, normal urine formation, we have both the ions. Sodium, potassium, bicarbonate are the important ones. But what we have on this luminal side, sodium channels, if the positive ions are removed, what is left over? Bicarbonate ions which are negatively charged. Okay, so the negatively charged bicarbonate ions accumulate in this part. Once there is negatively charged ions accumulating in this part, what can happen? There is a electronegative gradient which is created here. On the lower side, we have this potassium channels. Okay, where as there is electronegativity created here, some ions which are generated here should come out to maintain that. Okay, there is a negative pull which is created, suction, something like suction pressure for this positive ions. Why potassium is available here? Because sodium is going in, more amount of sodium is going in, sodium potassium ATPase system is working, and once the system is working, more amount of potassium is generated inside the cell. Okay, so that's why due to the electronegativity created, potassium is expelled out. Is it clear, the normal mechanism? Now, under the influence of this potassium sparing diuretics, spironolactone, we have decreased amount of sodium channels on the luminal side. Okay, that means less amount of sodium is taken in. That means no electronegativity is created. Both bicarbonate ions and the sodium ions both are stabilized. Is it clear? Okay, there is no, both positive ions and negative ions, they are at equilibrium now. There is no one to alter this equilibrium. So what happens to the pull for potassium here? If there is no electronegativity created, there is no chance that potassium ions from here will move out. Is it clear? Okay. So no potassium is coming out. That means the solutes which were already there, only those will be excreted, though they also contain sodium, potassium and bicarbonate. Okay. But the potassium which was excreted due to the electrical gradient which was created, that system is altered. That's how it becomes potassium sparing diuretic. Okay, and these channels we call them as epithelial sodium channels or the anhydrase. Okay, these potassium sparing diuretics, they prevent the potassium loss caused by other diuretics in hypertension. For example, you are using the loop diuretic and a thiazide diuretic together, or then we can think of a diuretic which can prevent this. That means in combination with either thiazide or the loop diuretic. Okay. In case of refractory edema, where the first line two drugs are not effective, you can go for this. You can use this drug in primary aldosteronism caused by increased production of aldosterone. Okay, primary aldosteronism, where there is increased production of aldosterones that will increase the amount of sodium channels and all these things. Directly, that action can be altered. And this spironolactone has also action on this hirsutism, which is produced by polycystic ovarian disease. Okay, so as it is an aldosterone antagonist, it can block most of the properties of this aldosterone. In case of cirrhotic edema also, you can go for this drug. So potassium sparing diuretics, amlodipine and triamcinolone, okay, you can directly block the epithelial sodium channels. Okay, these are the collecting drugs. Sodium is available there. We have a aldosterone which can bring, okay, which can bring in the sodium channel from inside the cell to outside the cell under the influence of AIPs. Okay. Okay. Now we have blocked this. We have blocked this using the potassium channel sparing diuretics or the spironolactone. What can happen? It will get excreted. Okay, so spares potassium by decreasing the lumen negative gradient that drives the expulsion of expulsion of potassium to the lumen. Site of action, cortical collecting drugs, blocking of the ENACs, okay, pharmacology will 3 to 5 hours. So how this potassium sparing diuretics help in lithium-induced toxicity? Okay, you remember lithium is a drug which is used in, where it is used? Mania. Okay, mania or the bipolar disorder, we are using this lithium. Whenever we are using lithium, we have a adverse effect called as lithium-induced polyuria, that is more amount of urine excretion. Okay, in case of this potassium sparing diuretic, we are blocking the epithelial sodium channels. These are the same channels through which lithium is reabsorbed. Okay, basic simple concept. It was absorbed back into the body as like our sodium. We are blocking here. What will happen? They are going out. Okay. So amlodipine blocks the lithium reabsorption through the sodium channels. Okay, so this reduces the lithium-induced polyuria. They can be used to treat edematous conditions, including liver cirrhosis, as they cause hyperkalemia. So combined with thiazides in the treatment of refractory edema. In case of hyperkalemia, for example, you know there is some metabolic disease, metabolic acidosis has happened, and the patient is having this hyperkalemia. Hyperkalemia can also be due to some renal conditions. Okay, in those cases, we need to avoid the potassium sparing diuretic. whereas potassium sparing diuretic are the drug of choice in cirrhotic encephalopathy, all these conditions. Okay. So potassium sparing diuretic should be avoided in hyperkalemia conditions. So drug interaction, we cannot use the other potassium sparing diuretic. For example, there is some refractory edema, you want to use two drugs together. Okay. You want to use two drugs together. That is something like loop diuretic or thiazide-diuretic and a potassium sparing. We have three alternatives. But we should not go for two drugs which are acting on the same side. For example, triamcinolone and spironolactone. You are never going for such combinations because they can cause hyperkalemia. Okay, so caution in ACE inhibitors, and in case of asthenia and triamcinolone nephrolithiasis, we need to be careful. Okay, the next group of drugs is the acetazolamide or the carbonic anhydrase inhibitor. Okay, in the previous class, the first topic I took about was the action of this carbonic anhydrase enzyme. Okay, we'll learn it now. It's the acetazolamide is a prototype carbonic anhydrase inhibitor developed from sulfanilamide. Okay, it can cause this metabolic acidosis and alkaline urine. In fact, we are using this drug for alkalization of urine. Do you remember where we need alkalization of urine? Acidic poisons, barbiturate poisons. Okay, we need alkalization of urine. So it has limited use as diuretic because they are poorly effective, but we can use it at specific conditions. It is well absorbed orally, excreted unchanged, action is about half a day. Here you can see, okay, this is the interstitial system, this is the luminal system. That day first what we discussed on the board, okay, the first concept. So from the luminal side, okay, from the luminal side what we are getting, sodium, bicarbonate, potassium, every ion is coming in. Okay, so the one of the ions is sodium. Sodium is transported into the cell in exchange to the hydrogen. How did we get this hydrogen? How did we get this hydrogen? Sleeping, sand. How did we get this hydrogen? This hydrogen has come out from the action of carbonic anhydrase enzyme inside the cell. Okay. When this acid was broken down, we got this hydrogen ion, which was exchanged to sodium, and sodium was reabsorbed back. This hydrogen ion, which has come outside, combined with bicarbonate and formed a carbonic acid. Carbonic acid, under the influence of this luminal carbonic anhydrase, was converted to hydrogen and carbon dioxide. Carbon dioxide is a highly diffusible gas. It can easily pass through the cell membrane. Once it has entered the cell membrane, we had water here to combine with this, and under the influence of carbonic anhydrase enzyme, this was converted to carbonic acid. Carbonic acid, under the influence of this, Ca can get converted to hydrogen ion and bicarbonate. So this was the mechanism by which we conserved our bicarbonate ions. Okay. Now we conserve the bicarbonate ion, and this bicarbonate ion has its own channels at the basolateral side, which can be taken up into the blood. Is it clear? So what happens if this carbonic anhydrase is blocked? What happens if this carbonic anhydrase is blocked? There will be no hydrogen ion present for the transport. Okay, we have this proton transporter. What was the proton transporter? With exchanging the hydrogen and the sodium. That system will not work now, because on the inside the cell there will not be any carbonic anhydrase present to leave out this hydrogen ion. Is it clear? So sodium is not reabsorbed. What happens to the bicarbonate absorption? What happens to the bicarbonate absorption?